So I've been given the task of talking about the spacers. I think two-stage exchange still remains the most preferred method of treating chronic periprosthetic joint infection, although there's been a move towards adopting the one-stage exchange, and hopefully with more data we will know which patients qualify for the one-stage. But in the meantime, with the two-stage exchange, the principles still remain the same: aggressive debridement, and as George Tierney would say, you need to get a clear margin, remove all the bioburden, remove all foreign material including cement, place the antibiotic cement spacer, and then direct the long-term antibiotics. So a case like this, you want to remove every bit of the foreign material and place an antibiotic cement spacer and treat the patients. What we don't know is whether we should use dynamic or static spacer, how much antibiotics we should add, and if, for that matter, which antibiotic. This was a subject of the last international consensus, and I'm sure we will discuss this further in 2018 when we reconvene. But some of the questions that were asked is there a functional difference in the use of non-articulating or articulating spacer in treatment of THA? And the consensus was, with 89% agreement amongst delegates, a well-performing articulating spacer provides better function. Another question is that dynamic spacer provides better ease in surgery. The answer was yes, again with 81% agreement. Which antibiotic and how much should it be added? We don't know, to be honest with you. At this point, it is based on organism profile, patient's renal function, the type of cement you use, allergy profile. But I want to warn you that FDA is sensitive to this issue, and in fact, there was a publication from FDA members who questioned the whole wisdom about adding antibiotics to cement spacer. That may come to you as a very big surprise, but they are right. There is absolutely no data that supports that common practice in orthopedic surgery. And until we generate that data, FDA will remain sensitive to the issue. Difference with regard to control of infection between articulating and the non-articulating spaces in the hip? No, not really, in terms of their ability to eradicate infection. Any contraindications? Yes, don't use dynamic spacer when there's massive bone loss, when the integrity of soft tissue is under question, or when you don't have the ligamentous restraints. So you can see there are more unknowns than knowns, and we need for future studies. Craig Della Valle and I have been in the middle of a randomized prospective study looking at this issue. And basically, the data is not ready yet. We're still recruiting, but it looks like the dynamic spacer patients have a shorter stay in hospital. They have a better functional outcome. That may not be statistically significant, but blood loss and operative time remains the same. Pre-manufactured spacers, they may not contain enough antibiotics. The issue sometimes remains with the offset and the cost, and unfortunately, they dislocate. So my personal preference is to make my own antibiotic spacer during surgery. How do I do it? Well, first, I actually use Pellicose. I believe it has better elution profiles. I add 3 grams of vancomycin, 2.4 grams of tobramycin. Again, Pellicose elutes better. It's better than Simplex. You need to really go dial down on your antibiotics. And then I mix 3 bags. I first actually get the vancomycin powder and the tobramycin mixed together. I really smash it up, then put the antibiotic. Then I usually mix it either in these pre-mixed bottles, or I actually mix it with hand. So here's how I make my antibiotic cemented spacer for the hip. 2.4 grams of tobramycin, 3 grams vancomycin again. And if I have organisms that don't respond to those antibiotics, I then add a different thing. If I have a fungus, I would add voriconazole and possibly a little bit of amphotericin. This is the bulb. I cut the bulb first, and then I suture the bulb together. I decide on how big that how big the acetabulum is going to be. Here we have a 54 millimeter acetabulum. I get the 6.5 shank pin. I cut it to length. I then, based on the broach, bend it at the neck of the stem, where the potential stem is going to be. At this point, I have had the powder and the antibiotic added together, but as you can see, I wait until I've made my provisional head before I mix the monomer to the cement. So a couple of sutures, and then we start to So that's going to be as large as the acetabular component that I'm going to be using. And if it's going to be smaller than that, then I would usually utilize a smaller bulb. So at this point, we're ready. We add the 3 packs of cement and 3 monomers. Then we start to mix. And the mixing, I do that with hand. It does not matter. You don't really have to have this under vacuum. You want to have as much bubble and as much of irregularities in the cement as possible. In fact, I used to add what I called filler, and the filler used to be usually xylitol, alcohol, or you can sometimes add seaweed in order to provide better illusion. You want to have as much bubbles and as much surface area as possible. So we mixed that together, then we started to put that around inside the bulb, and now I'm trying to make the stem. Shanspitz goes inside, and again the cement is not set hard yet at this point, so I will play with that to make sure that that sets as quickly as possible. It is important to make sure that you don't make this too thick or too long, because it will not go in. Especially if it's too thick, it's going to crack the femur. Very important to make sure it's thin profile. Again, I just keep checking it against the broach that was inside the femur, and that was the appropriate size. Sometimes the broach is much smaller size, in which case you really need to make sure you make it thinner. And we will basically play with this to get it to the right shape and wait for the cement to set hard. Couple more seconds, Tom, and then it'll be done. At this point, you have that surface really smooth as well, and we've got the bulb and the connection with the Shanspitz. So that was a little too long. I again checked it against, and we thinned that out. This usually takes about 3, 4, 5 minutes in the operating room. Now the cement is hard. You can then just remove this bulb, and here you are. You have your dynamic spacer. Now, if you wanted more offset, then you bend the Shanspitz a little higher. You can modulate your offset. And so far, it's worked very well, and I have not had to take any of those fractures. Thank you very much.